Hi everyone. Uh, so, how many of you are measuring or giving importance to the triglyceride? Please raise your hand. Or you are just seeing LDL. Significant, almost I would say 60% of you are now taking a care of triglycerides. Of course, it was a neglected and ignored one of the cousin brother of lipids. And let us understand what triglyceride can cause. So I am not going to go into the details of lipid metabolism, but I would like to highlight a couple of the things. When you see the lipoprotein which carries the cholesterol inside the blood from one part to the another part of the body, the majority of the lipoprotein core is made up of triglycerides. As it starts metabolizing to chylomicron, VLDL, goes up to the LDL, the cholesterol esters which is in the orange increases while the triglyceride which is in the blue reduces. But remember these things, I will come back again when I am talking on a fibrates, that even LDL has a triglycerides inside its molecule. So that is number one message. Number two is when we are measuring the triglyceride, it is very important to measure in the fasting stage. The reason is when you do a non-fasting, the majority of the part you are measuring is chylomicron and chylomicron remnants. So the reflection of the actual triglycerides, which is ideally VLDL remnants are not calculated, and then you get the false high triglycerides because of the chylomicron. So it has to be done in empty stomach. Ideally, around 14 hours is the recommended fasting period for the triglyceride measurement. And lastly, and most importantly, when the triglyceride is measured, as I mentioned, it measures the triglycerides which is inside the LDL also. So remember that all the lipoproteins which are carrying the cholesterol has the triglyceride inside. I will just briefly give you what is the triglyceride and how do you classify the triglyceride. What should be the normal? Up to 140 we considered it is a normal. Up to 140 to 200 we call it is elevated. High blood pressure just elevated. Hypertriglyceridemia is diagnosis after 200 to 750, and above 750 we call it is a severe hypertriglyceridemia. If you look the causes of the hypertriglyceridemia, mainly related to the lifestyle. So what it consists of? Lack of physical activity, unhealthy diet, all the colleagues has spoken, metabolic disorder which we are increasing the obesity, pre-diabetic, diabetic, overweight, and most importantly, somebody has told that alcohol no reduce nathi thatu, shrenic. Here the alcohol plays the major role and I will explain you how. When you see the triglyceride which is above 700, do not think of all this cause, only think of a genetics, either it is a multigenic or a monogenic, and it is very dangerous for pancreatitis as well as the atherosclerotic coronary artery disease. Now, after listening the LDL talk, in our mind we are fixed that LDL is the only responsible. Do we have the evidence that triglyceride can increases the cardiovascular disease and the mortality? So these are the recent data from the ESC. If you look at the cardiovascular mortality, which is higher after the 200 and above. So if you see the hazard ratio of anything, hazard ratio of more than 1 is we considered as a significant. So above 200, the hazard ratio is almost reaching up to 2. And which is very significant. Not only it reduces the increases the cardiovascular mortality, all cause mortality is also increases in the after patients with the hypertriglyceridemia. So very clear message that triglyceride is a very important for reducing the cardiovascular disease and the mortality. Now how this triglyceride can cause coronary artery disease, pancreatitis, fatty liver and other things. Let us understand little bit into the details. When this chylomicron, which contains the triglyceride as a major component, which metabolizes and it releases this free fatty acid. This free fatty acid is the most dangerous and pro-inflammatory. It only not affect the pancreas, it causes the fatty liver, it also increases the inflammation in the coronary artery, coronary circulation, cerebral circulation, peripheral vascular disease, and then subsequently chylomicron further metabolized to LDL which further aggravate the atherosclerosis. So this triglycerides and free fatty acid is primarily responsible for all the problem which is happen with the hypertriglyceridemia. Now we have the baskets of the drugs which every lipids lowering agent has, and then we have statins, we have PUFA, which is again omega-3 fatty acid, we have fibrates, and then we have couple of the newer drugs. Let us understand one by one. So this is the basket of the therapy which we have with the reducing the hypertriglyceridemia. Now most importantly, how many of you are using fibrate as the first line of therapy for hypertriglyceridemia? Raise your hand. Very less. So what you are using? Now let me ask you, what you are using? Statin you are using. Great, great. So I am surprised to see that you all are using statin, but prescription does not reflect it. So let us understand that statin is the drugs which are in the blue, in the green, which reduces the cardiovascular mortality. So if you look at the statin intensity, moderate and high intensity statin reduces by 20%. PCSK9 reduces by 26%. And hence, statin is the first line of therapy which is recommended in all the guidelines, which is LAI guideline, European guideline. Statin is the first line of therapy in a patients who are having a proven atherosclerotic coronary artery disease or those who are at the high risk. Remember, it is moderate and high intensity. As I mentioned in my introduction speech, use at least a 20 and above statin along with the ezetimibe, as Nilesh has also pointed out. The second group of the drugs, our favorite and which I see very commonly people are prescribing in a combination, is fibrates. And look at that evidence. It reduces significant number of the triglycerides by 44%, but does not trickle any benefit to the cardiovascular disease and mortality. So you are just reducing the number without any benefit to the patient. So you have to use carefully, and when to use we will discuss it. So this is the trial where they have used the penofibrates, and it reduces the cholesterol by 26%, but there is no mortality benefit. So that is very important. Most interestingly, what I had shown my first slide is, when you are using the fibrate, it reduces the triglyceride, but remember, it increases marginal LDL, which you have all observed while you are using the fibrate. And hence, when you are using a fibrate, it has to be associated with the statin in a lowest possible dose. Why? Because penofibrate with the statin can result in rhabdomyolysis, myalgia, which is very significant number, and sometimes AKI. So this study which has shown that it increases the LDL cholesterol by 10%, and hence again I am come back to my original slides, that why? Because you are reducing the triglycerides by penofibrate, the molecule become gradually smaller, but if you look at the LDL also, it has around 20 to 25% triglycerides. So reflection of cholesterol ester will be more, and hence you will see more LDL in the blood after removing the triglyceride by penofibrate. So remember, penofibrate, just a numerical benefit, but it has a role certainly in a very significant. Isopentyl ethyl, which we know as a omega-3 fatty acid. And there are various combination of omega-3 fatty acids which are currently available. So first is the purest form, icosapent ethyl. Second is icosapent ethyl with deoxyhexanic acid, which is DHA, which is used in another study. And third was the study which has been conducted, which is an omni study with the lower dose of the EPA with DHA. So what I wanted to again highlight is, green is only with the icosapent ethyl, it is not with the another two. Let us understand little bit onto the details of that, because it will gives you idea that what exactly you are supposed to do when you are dealing with the patients of hypertriglyceridemia. So these are the omega-3 fatty acids which are currently available. Majority of the commercially available are these two combination, which does not reduces the cardiovascular mortality. It reduces thus again the number. So number is not important. We have to prevent the cardiovascular disease. So these are the two interesting study, reduce it and the strength. The reduce it study was used with the icosapent ethyl, which is the purest form of omega-3 fatty acids. And if you look at the data, it reduces the triglyceride by 25%. At the same time, it reduces the cardiovascular event by 20%. The strength study, where they have you compared omega-3 fatty acid, which is a combination of icosapentyl ethyl with dexohexanoic acid, which reduces the again triglycerides by 25%, but without significant reduction in cardiovascular mortality. Why this has happened? Let us understand that both the trials, they have used a different combination. Here they have used a mineral oil versus the corn oil, which is an active competitor. So corn oil also reduces the triglyceride. The effect in triglyceride reduction is similar, but the safety profile is less. Now let me tell you that majority of the time our education comes, sorry to say, from the medical representative, and they push you to use the ISEP to the dose of 12 milligrams. Now what has happened? First of all, all the study have used icosapentyl ethyl in the dose of 4 grams. Beyond 4 grams, I would say 6 gram, there is a plateau effect. તમે ગમે એટલી આપો, વધારે ટ્રાઇગ્લિસરાઇડ ઘટવાનું નથી. But it will increases the incidence of atrial fibrillation. So your mortality increases rather than getting benefit. So do not use ISEP or icosapent ethyl more than 4 to 6 gram in your clinical practice. So this is a very important message I wanted to convey everyone. Though I am not seeing a major prescription, we still use the fibrates very aggressively along with the statin, but it will not going to help in a majority of the patient. This is the last study which they have shown a lower dose of ISEPs with the dexohexanoic acid, where patients, elderly patients with the recent myocardial infarction does not shows the benefit. So what the guideline says, we will come back again on this topic. Let me go forward to Indian guideline first. Though Satyam is going to cover, but let me go very briefly and fast on the LA guideline, what LA guidelines say about the hypertriglyceridemia. The aim first is to reduce the LDL cholesterol. Aim 2 is to reduce the non-HDL cholesterol, and then you target ApoB, means you target the triglyceride. So they have divided the LDL into the 4 groups. So 200 to 400, sorry, 200 to 500, 500 to 1000 and 1000 and above. Let us understand the first guideline, the up to 200. What you have to do? Measure first the LDL, find the risk factor profile, whether patient is at the high risk or patient is at the low risk, and then start acting on a lifestyle modification. I am going to talk in my upcoming slide. So let us understand that patient's triglyceride is up to 200. What you will do? You have measured the LDL cholesterol, you have find out his risk factor, and then if you find his LDL is high, his non-HDL is high, and he is at a high risk of atherosclerotic cardiovascular disease, what you have to do is add statin with ezetimibe. That is the first to achieve the LDL target. So up to 200 of triglyceride, you do not add anything isopentyl ethyl or fibrates. Number one message. Now 200 to 500, this is what commonly observed in our clinical practice. Majority of the patient of ischemic heart disease comes in this category. So you have measured his LDL cholesterol, you have measured his non-HDL cholesterol, you have seen his atherosclerotic cardiovascular disease risk stratification. What you have to do is you have to start statin with the ezetimibe to achieve the LDL target. So first goal is to achieve the LDL target. Now after using these drugs, if your triglyceride is still more than 140, you use icosapentail ethyl, that is omega-3 fatty acid, or you use a fibrate. So first drug comes is icosapentail ethyl rather than going with the fibrate. Now second subset of the group, 500 to thousands and above. It remains same. 500 and above, you have a very high chance of developing pancreatitis. So it is not only atherosclerotic cardiovascular disease, it increases the pancreatitis. So first of all, the diet comes the first. I will again talk into that. And then we will again see what we can do as a Indian LAI guidelines. So 500 and above, dietary exercise and everything you have done, go directly on fibrate and omega-3 fatty acid combination. So here the combination works. So you have to use all the three group of the drugs to reduce this. Consider statins to achieve the LDL target. Use fibrates to bring down the risk of pancreatitis, and use icosapent ethyl to reduces the cardiovascular disease. So all these three group of the drugs are required once you are dealing with the more than 500 and above. CSI guideline also talk on the similar line. If your triglycerides is normal, only lifestyle modification, and then see whether it is your triglyceride has come down or not. High triglyceride up to 500. If your patient is diabetic or proven atherosclerotic coronary artery disease, go on the statins and icosapent ethyl. If your patient is on a low risk, either only statin and lifestyle modification. More than 1500 and above, start using fibrate, ISAP, statins and newer drugs. So this is what now come to the food. આપણે બધા જ પેશન્ટો સૌથી પહેલો પ્રશ્ન પૂછે ખાવાનું શું, ભલે ફોલો કાંઈ નથી કરવાનું. અને here શ્રેણિક it comes the alcohol, that where the alcohol is. So out of all the lifestyle modification, the maximum reduction in the triglyceride comes with the abstinence of the alcohol. It reduces the triglyceride by more than 10%, and the level of evidence is A. Weight reduction reduces the triglycerides by less than 5%. Most importantly, we blame always the fat, but we never thought that carbohydrate is more dangerous for triglycerides and fatty liver as compared to the fat. So look at the dietary carbohydrate, 10%, again, class 1, A. But look at the fat, it falls to the B. So in nutcrux, one need to be abstinence from alcohol, weight reduction, exercise, and carbohydrate reduction, which is most important. When it comes to triglycerides of more than 500, they recommend zero carbs because your risk of pancreatitis is high. Your drug reduction capacity to bring it down less than 500 is sometimes very feeble. I have a patient who comes with 1500, 1400. We all cardiologists and physicians are treating, and it is extremely difficult to bring down to less than 500. So carbohydrate, zero carbohydrate diet is been recommended in this. So this is what about all about the diet. What is being preferred is the whole grain, cooked or raw vegetables, lentils, beans, peas, fresh or frozen fruits, non-caloric sweetener, particularly stevia is recommended, lean and fishy oil fish which are lean, skim milk and yogurt formed from the skim milk is recommended. If you want to have a dressing, either use olive oil or a vinegar, and for the cooking the method is either steam or a boiled rather than it is fried. What is not recommended, which is more important, is these particular foods, all cheese, pastries and all the bakery products, ghee, oil, particularly coconut oil in the south, which is very famous. You should not use the coconut oil for particularly hypertriglyceridemia. So what I wanted to give you in a diagrammatic form, if your triglyceride is normal, if your liver is normal, heart is normal, your body is this, is good. You should avoid these fat and fatty acids which can result in fatty acids, hypertriglyceridemia, results even in pancreatitis. Now, many a patient comes, સાહેબ મને 3 મહિનાનો ટાઈમ આપો, હું 3 મહિનામાં ગાર્લિક ખાઈ, સોપારી ખાઈ અને મારું બ્લડ પાતળું કરી દઈશ. We all receive these questions, and this is an interesting study which is recently published, sports study, nothing related to sports. It called supplement, placebo or rosuvastatin study. Only 195 patients, no atherosclerotic coronary artery disease, but elevated at high risk of developing atherosclerotic coronary artery disease. What they've done is they've included the patients with the LDL from 70 to 190 versus the placebo, and primary endpoint was 28 days, 1 month reduction in the LDL. They also measured the triglyceride as a secondary endpoint. And what they've used is placebo, fish oil, cinnamon, garlic, turmeric, plant steroids, and red rice. Again, red rice is again back in the picture. Many of the guidelines says red rice vapro. Now, too important, આપણે જે બધા કહે છે ને કે હું garlic ખાઈને reduction કરીશ. Garlic increases the LDL cholesterol by 5%. These are real data. So do not go by the other things. Garlic increases, but at the same time, it is helpful in reducing the triglyceride. Yeast or red rice decreases the LDL by 6%, but it increases the triglyceride by 4%. Most importantly, 5 milligram of rosuvastatin, nearly 40% reduction in LDL cholesterol and nearly 20% reduction in triglyceride. So lifestyle modification is important, but what the recommendation by the authority is that dietary supplement, garlic, બધા આપણા સોપારી and vitamins without document safety and significant LDL lowering effect is not recommended. It is class 3B indication. So this should not be tried. ઘણી બધી આયુર્વેદિક દવામાં dried and the form of the garlic આવે છે. Lastly, I'll just speak on the volonasorsen, which is again anti-sensing oligonucleotides. So let us understand, after 500 what has happened. After 500 your triglycerides results in more linearly been observed to increases the pancreatitis risk. But remember, at one point of a time above 200, the myocardial infarction rate becomes stationary. Now, what I wanted to give a message to physician and my gastrologist is, even you get a pancreatitis as low as around 170. So do not think that always pancreatitis is autoimmune or some other causes. Look at the triglyceride. Triglyceride is very important and it can result in pancreatitis at any level, though it is very high after the 500. What are the drugs available? Is currently all anti-sensing oligonucleotides. These are not available, but one need to think about it when it comes to hypertriglyceridemia above 500 or 750. It reduces the triglyceride level by 77%. It reduces the incidence of pancreatitis by 88%. So another molecule which is also not available in India, and this is again sRNA molecule which reduces the pancreatitis. These are like inclisiran. If it is available, will be a exorbitantly high cost. So what I wanted to give a message, last message and last slide. Start with the statin ezetimibe combination. Try to achieve the LDL goal, non-HDL goal as class 1B recommendation. And when it comes for a atherosclerotic cardiovascular prevention, icosapentalethyl is the only purest form. Use up to 4 to 6 milligram. Do not try to go beyond. It is 2A. Now when I call 2A, there is a substantial evidence in favor to have the benefit. When I say it is 2B, there is a no benefit or it may not be used. So 2A, level of evidence is B. B means one randomized controlled trial or one large non-randomized trial which favors the use of this particular molecule. And when you want to prevent the pancreatitis, Look at all the newer drugs which are anti-sensing oligonucleotide or sRNA based therapy. So thank you for patience listening.